We will welcome to this evening meet today uh, from the PGI Alumni Welfare Association, and thanks to Dr. Smith for making us together. Really a good effort. And today it's my pleasure to introduce Dr. Arun Gopi. I have come to know him very recently, and he's an aggressive and a very sensible interventional cardiologist doing all sorts of things. And today he is going to take us through the uh, worth of laser in cardiac interventions. Dr. Gopi.
Start sharing slides. So are my slides visible and am I audible?
Absolutely, sir.
Yeah. So thanks, Anshu sir. Thanks, Smith, for the opportunity. Thanks, Ojate, for the opportunity. And it's always a privilege to be among you all and to discuss about an upcoming adjunctive technology for PCI, which has made sometimes life easy for us in the cath lab. So before I start, salutations to our PGI Cardiology Department. This is Temple of Cardiology, from where we learned everything that we know. Our salutations to the teachers, our teachers there who have actually made us what we are, and big greetings to all my friends there. They are a pillar of strength, and they are actually the real encouragement for us to move forward. So excimer laser, as you all know, is actually a long-established adjunctive therapy to PCI. It uses pulse gas laser. Wavelength is about 308 in UVB range. It is actually causes less of heat production and less unwanted damage when it is in this range. So the mechanism of action is one that has been intuitive. Actually, it acts through three ways. It acts through the UV light, which breaks the molecular bonds. It acts through a sonic wave, which actually cracks the hardened tissues. And the actual debulking happens from cavitation. We'll go on this mechanism one by one. So if you look at this, the UV light, the high-speed camera on view of it, the UV light actually starts breaking the molecular bonds in 50 to 100 microns from the catheter tip. That is the first step that happens. As it breaks the molecular bonds, then comes the sonic wave, which actually gets emitted from the catheter tip, and it actually goes through after the bonds have been broken. And the sonic wave actually creates the so-called the cracking effect. It actually changes the vessel compliance. This energy actually reaches much beyond the catheter tip, as you can see in this animation. The UV light actually reaches only till up to about 50 to 100 microns from the catheter tip, but sonic wave actually, the energy reaches much beyond the catheter tip, in fact, impacting the hardened tissues like the calcified tissues, creating a change in the vascular compliance there. And the actual debulking happens with the cavitation. The cavitation actually occurs in the wake of the sonic tissue. It converts the sonic tissue into mechanical energy, creating a microjet. As the picture shows, it actually, the cavitation bubble collapses, creates a microjet, which actually breaks apart the tissue into smaller pieces, much less than that of a red blood cell. So this is the actual debulking that happens with the cavitation. So multi-step mechanism of action, the UV light breaks the molecular bonds absorbs the high energy of UV range. The sonic wave actually impacts the hardened tissue, actually improves the vessel compliance, that the one which acts on the fibrotic tissue. It actually it's created in the wake of breaking of the molecular bonds. An actual debulking or the real volume reduction happens with the cavitation, which actually creates a microjet to macerate the lesions. So there are three mechanisms: photochemical acting through the light pulse, which actually you can see. It's actually a photoablation, actually. So the light pulse actually goes through the molecular level by breaking the molecular bonds. It debulks the lesion, improves the vascular compliance. The next comes actually the photothermal. The photothermal actually creates a thermal energy. So here, the first part, you can see the photochemical vaporizing the chemical bonds. It actually acts You can actually see what happens at the molecular level. Actually, it breaks up, but it acts only at the tissue tip. It softens the plaque. As it acts on the the fibrocalcific plaque, it softens the plaque. Then actually the photomechanical effect happens by hammering the hard tissue, impacting the rigid material, changing the vessel compliance, and finally debulking happens from the cavitation. So it does not cause any damage to the normal vascular tissue, almost has zero, very less embolization risk, as you will see as we do on, we handle it in thrombotic lesions or with degenerated grafts. The three important things while you're handling laser is to know how to handle the catheter, know what settings you want to make, and how you adjust in different scenarios. So when you're handling the catheter, the most important thing in laser, as like an orbital, is to have patience. So let the laser work for you. You need to understand that you need to be very patient and go very slowly, because the slower you go, as you can see in the picture, this is the thing that will be emphasized more and more in the presentation. The slower you go, that means slower means less than 1 millimeter per second, if you actually measure it up. The slower you go, that the more luminal gain you get. The faster you go, you'll scrap through the lesion, but the luminal gain will be less. So sometimes if you go slow, you will be able to get a bigger luminal gain and the number of passages will be lesser. But if you go faster, you might have to go later on with slower passages to get bigger luminal gains. The power settings, again, two important things that are important is one is fluence. So when we say fluence is nothing but the power or energy of laser. So when you're deciding the size of the laser catheter, typically like a rotor, the ratio should be 0.6 or 2/3 of the vessel size, because the cavitation bubble typically expands to 50% greater than the catheter diameter. And you should preferably always do saline lacing. So flush off all the contrast, get saline in the medium and do saline lacing. Typically, they say the maximum bubble can be created up to 3 times the catheter size. So 0.9 mm catheter is safe up to a 2.7 vessel, 2.7 mm vessel. So never use laser in a vessel which is less than 2.5. And any vessel from 2.5 to say 4, it is preferable to use 0.9, and above 4, or like large venous grafts, or say 3.5, 4 above vessel, using a 1.4 catheter is fair. So when you're using lacing, majority of the time we do saline lacing. But when you want high absorption, do a significant amount of debulking, you can use contrast lacing as well. Now, other important thing that is in your hand is the frequency or number of pulses that you can use. So it's just like jackhammering, how much times you want to laser to beat for you in a particular second. And for the UV light actually acts in the first 125 nanoseconds. The sonic wave acts in the 200 microseconds, and cavitation bubble is the one which acts for the 300 microseconds. So when you use a 25 hertz rate, it's actually 1.3% time of the time the ablation happens. For 80 hertz, it's about 4% of the time that the ablation happens for a single laser pulse. The initial laser is nothing new. Actually, it is there from, we got FDA approval in way back in 1992, but it was not much used. It had a lot of warm-up period. This was such a bulky equipment, but the newer technology, the next generation laser system is quite handy. As with any of the newer AI tools, it is plug and play. You can actually roll it in forecaster wheels to wherever you want. And it starts as early as 30 seconds compared to the 5-minute waiting period that we have. And it can use in any of the labs, but it's quite a bulky equipment to transport. So there's no mobile systems available. You need to have this console in your lab for us to use it. The typical indications in the coronary tree are instant restenosis, moderately calcified lesions, ostial lesions, lesions which have failed the conventional angioplasty techniques, CTO where you have transverse that wide web and nothing else passes, occluded saphenous venous grafts, and long segment lesions where you need significant debulking. We'll be going on each of these scenarios as we go along the presentation. So this is the typical catheter that we use. It has a proximal coupler as is shown in. And if you see this catheter, it is engineered so beautifully well that if you take a cross section, you can actually see 61 microfibers. Each of these fibers are 61 micrometers. And there are about 65 to 250 fibers in each of these catheters. So this is a cut section of a laser catheter, a 0.9 rapid exchange catheter. It has other extended use for as if you want to go beyond the coronary tree. The peripheral system, again, you find it a lot of useful in instant restenosis for a good debulking technology. Uncrossable CTOs is something like a javelin concept where you knock off the laser at the CTO bulb, a proximal cap, and then probably it softens out the lesion and allows you to cross. for long segment lesions, for thrombotic lesions, for lead extraction. So this is one technology where it is actually the most safest technology for lead extraction for any of the old, even for the older leads, much safer than the mechanical technology. Actually, we use, there's a specific glide light laser sheet, which actually works on the same 25 to 80 hertz. About 50, you require less of force when you're using this, about 55% lesser force, and almost 62% more efficient than the typical mechanical extraction tools. We have a lot of data with laser, almost 30 years of clinical data with laser, with almost 95% procedure success rate, very few complications, 0% perforations, 3% major dissections, 0.6% risk of embolization from the largest Carmel study. And as you see in the slide, there are numerous other studies which I'm not going to go delve into further. The LAVA registry is more important because it looks at what the contemporary practice of laser is. So if you look at the typical indications, so most common indications for laser in the VA registry was balloon uncrossable lesions or balloon non-dilatable lesions. And almost 70% of operators actually used the 0.9 mm catheter. The typical 5SS score, a successful laser use is to select the right patient, use the proper sizing of the catheter. The tighter the lesion, use the smaller catheter. I would say that almost 0.9 is going to be a workhorse catheter, which works in 90% of cases. Again, the settings that you want to use, again, go slow to get gain better, and then gradually up titrate your settings. Typically use saline lacing, about 1 to 2 cc per second would be a flushing speed. And as I said, the slower you go, the more lumen you gain. Typically restrict your speed to less than 1 millimeter of your coronary tree per second of advancement. It is actually a beautiful technology, but compared to rotablation or orbital, this is a technology which works across morphologies. You can use it for a very fibrotic plaque. You can use it for a very calcific lesion. You can use it for a degenerated venous graft. You can use it for a late presenting thrombus. So different morphologies, this technology works. Now, depending upon your setting. So depending upon your lesion, you decide your setting. Preferably for a good amount of debulking, like a significant stent failure, neointimal hyperplasia, you want good absorption of laser technology. It is preferable to start with 45 fluence, 25 rate, go slowly, then increase your settings as you go for the second pass. Now, on the other hand, thrombus, you need high fluence, you need increased luminal gain. There you go 1-to-1 catheter size ratio. You're not going at a smaller size. You need to debulk further. So that is why typically for large vessel thrombus, for SVG grafts, use 1.4. That is typically the indication for 1.4 catheter. And you actually go at 80-80. Calcium is an X factor because calcium is one arena where laser would still be not the best technology to be used. But sometimes where your rota wire, I'll be alluding to in the cases where you're not able to get your microcatheter across, it definitely works. In focal calcified lesions, definitely laser is a debulking technology which you can use. But again, keep your expectations low. If you expect less, you will be obviously happy with the benefit of laser in calcified lesions. 2/3 is the rule. As I said, your catheter size should not exceed 2/3 of the vessel size. But if you don't want to go calculate 2/3, just subtract 1. So typically, you should not lace in vessels less than 2.5. And for anything above 2.5, start with a 0.9 mm catheter. Anything like 3.5 or 4 vessel, you can use a 1.4 catheter. Fluence and rate, again, as I said, the fluence decides the size of the vapor bubble. Higher the fluence, higher the vapor bubble, and higher amount of debulking you're going to get. While rate is actually the jackhammer effect you're going to create. Typical settings are used to start with 45-25, and as you have subsequent passes, you need to go higher and higher. So you can see the bubble sizes from a 30 and 60 fluence. The larger fluence use, the larger bubble size that you're going to get, and larger debulking you're going to get. As I said, you have typically for all the operators you have used laser, you will find that there are 2 catheters, 0.9 and 1.4. 0.9 works at the maximum setting of 80-80. There you lace for 10 seconds and then you have a 5-second resting period. While 1.4 catheter, you will lace at maximum 60-40. The maximum setting for 1.4 is 60-40. And you have 5 seconds of lacing only and a 10-second off. This is primarily one reason why we still stick on to 0.9, because at 0.9 you can lace at 80-80 and you have 10 seconds of lacing and only 5 seconds off. But on the contrary, with 1.4, you can only lace for 5 seconds and you have 10 seconds off. Again, for calcium, keep your expectations low. But if you're going very slow, you can have calcium fractures as shown in this picture. But again, it's always better to start at high fluence, high rate, go slow. You need to have the smallest catheter. You need to get the catheter in contact with the calcification. Downsizing catheter is always a good strategy. It works typically in moderately calcified lesions. You need to be extremely patient to hit this calcium. Heavily calcified lesion laser is not a technology that would be useful. It's always rota. Again, do with saline. As I said, it to be 1 to 2 cc's per second. You can, if saline lacing does not work, you can do blood lacing. And in complicated lesions also, you can do contrast lacing. Because if you look at this is what happens with saline lacing. You can see the size of the bubbles that happens. But on the contrary, you see contrast lacing. You can see the size of the bubbles that happens. This is the big bubbles that happens with contrast lacing. So with contrast lacing, you have typically big bubbles, and that's where contrast lacing can be dangerous. So you should use it only when you are inside a stent or in a large calcific milieu where you're protected. But again, your indications, your complication rates go higher as you start using contrast lacing and should not be advocated in your initial usage. So go slow. As I said, 1 millimeters per second is your typical pattern. So typically for a 6 centimeter lesion, you should typically take at least 1 minute to cross. So this is again and again emphasized. So if you go slow, this is the lumen that you gain. 6 mm is the lumen. Well, if you go fast, again, the lumen gain is about just 3 mm. So slow advancement is the most important thing in laser. So slower advancement, actually you get better lacing, better plaque reduction, and you get larger lumens, cleaner lumens, and lesser chance of even dissection. So lesser complications, you need to be patient, and you get more and more debulking. Another important thing for operators as well as technicians is laser safety. It is typically 308 nanometers, which is invisible to human eye. And what we use laser is actually a class 4 laser, and it's a class 3 medical device. But everyone in the room, including the patient, must wear an eye protection. And you should never directly view the laser beam, even with a proper eye protection, like when you're actually calibrating the vessel, or should never press the button outside. When outside, and never view the laser, even with a protected eyes. And always handle the catheter with care. Never point the catheter at anyone. So typical catheter size is 0.9 into by 80. It's actually compatible on the 014 typical guide wire. 6 French guide compatible. Minimum vessel diameter, although in the picture says 2, but it's preferable to avoid lacing in a vessel less than 2.5. The fluence, the range is between 30 to 80 and weight is between 25 to 80. You lace for 10 seconds and have a gap for 5 seconds. Again, for 1.4 catheter, again can be advanced over 014 wire. Requires typically a 7 French guide that's most comfortable. Minimum vessel diameter should be 2.2, but again, we don't lace any vessel less than 2.5. The working length is 130 centimeters, and the fluence for 1.4 is maximum up to 60, and maximum rate is 40. You lace for 5 seconds, and you have waiting period for 10 seconds. So typical indications are balloon non-crossable lesions. That is, after guide wire pass, the balloon does not cross, or balloon non-dilated lesions, where the balloon passes, but despite high pressure balloon inflations, the lesions don't expand, and late arriving thrombus and degenerated grafts. Laser, the advantage is it allows easier delivery of hardware. It ensures better stent deposition, reduction of stent failures, lesser chance of distal embolization, and reduces your stent usage, and also allows the balloon to expand at lower pressures. But the beauty of laser compared to any of the other debulking technologies is you don't need any additional wires. You don't need a rota wire, you don't need a wiper wire. You can work on your workhorse wire. You can just work on your conventional 014 PTCA wire, and you can actually work as soon as your wire passes across the lesion. The major limitation is it does not work in heavy calcium, where it can work hand in hand with rota. So typical indications in the coronary tree is chronic total occlusions, balloon or microcatheter non-crossable lesions, underexpanded stents, balloon non-dilatable lesions, moderately calcified lesions, not heavily calcified lesions, degenerated grafts, thrombotic lesions, postal and long segment lesions. So we have been using laser since July 2024. We have done about 60 cases till now. Majority, as you would see, is in stent failures, is in instant restenosis, balloon non-dilatable lesions and balloon non-crossable lesions, degenerated SVGs, and late arriving MI other indications. In calcified lesions, we have had to use additional debulking tools like rota or cutting balloon in significant proportion of cases. And with laser in instant restenosis, in significant proportion of patients, we have been able to do metal-free PCIs with a combination of laser debulking and drug-eluting balloons. Acute procedural success rate has been 100%. One major complications have happened. I'll go to case scenarios. We'll start off with some scenarios which was actually a no for interventions. That is, we'll start off with degenerated grafts. The first story is of 72-year-old post-cabbage in 2010. Had frequent PVCs not managed with amiodarone, significant PVC burden, had a papillary muscle PVC, which we ablated about 5 years back. Had a check angio at that time, which showed a patent Lima to LAD and SVG2 OM grafts the patent, and SVG2 PD was already approved from the osteal. Was on optimal medical therapy. Had an NSTEMI in 2024. Had lateral evidence of lateral wall ischemia. Treated with medical therapy. Had nothing much of PVCs in this time Holter. They can manage him conservatively since it was already 14 years back SVG. They managed him medical therapy, but he continued to have recurrent angina requiring sublingual nitrates after that. He came to us 3 weeks after his index admission with unstable angina, with recurrent rest angina, with dynamic EC changes, not recovering with sublingual nitrates. And so this is the native triple vessel disease. You can see LAD is occurred from the ostium. L6 was non-dominant, giving collaterals to OM major. The RCA was an ostial fetio. Lima to LAD is patent. It is giving collaterals to the RCA. The SVG2 PD is occluded from the graft itself. The SVG2 compared, we had already an angiogram done in 2019 when we did a PVC ablation for him. And compared to that, the culprit lesion is clearly this thrombus-filled degenerated SVG2 OM. This was the one which was causing him refractory angina. This is the lesion which is there for at least last 3 weeks from the history itself. Typically, for this late arriving SVGs, our typical experience with the conventional angioplasty is quite disastrous. So conventional balloon angioplasties typically don't work in this. So we thought of using ELCA and how ELCA fares in this. So typical axis is right femoral axis, GR 3.57 French, workhorse wire down the lesion. There is no DPD use because there is no typical landing zones. As with the workhorse practice, 2.520 balloon was tried. Obviously, the balloon in these cases you will find absolute no flow, worsening of flow. We start off with lacing. We start off with a 0.9 mm catheter. Multiple passes are done. We start off with 40, gradually increase to 80/80. We do a guide extension assisted lacing. That's a Guidezilla assisted lacing. 0.9 mm catheter with 80/80 runs done. We do initially saline lacing. You can see this dot catheter, that's a laser catheter work. Typically passages like how you pass a micro catheter over a 0.14 wire. We first do saline lacing. And after that, we stop the flow of saline and do some blood lacing. We need to do it very slow. As I said, in lacing, it's all about being slow and steady. Multiple runs, it's always guide extension assisted because guide extension ensures that laser stays in the center. We take about 6 minutes of lacing time, multiple lacing passes done. Then we do a pre-dilatation with a 3 to 25 balloon. All those fibrotic lesions start yielding up at high pressures. And then we do overlapping stents with 350, 3.538, and 3.533 from proximal to distal part of this SVG. So multiple overlapping stents are placed. So almost we may do a metal jacket on this SVG. So this is what happens at the end. So you see a TIMI3 flow in the OM major, no distal embolizations at all, despite using no DPDs. This patient was discharged on day 2, absolutely asymptomatic on follow-up. You see on follow-up echo, there's full recovery of LV function. And during the entire PCA, there was no significant PVCs at all. So papillary muscle PVCs are gone off with ablation. And this is a story of a 14-year-old degenerated SVG, presented late 3 weeks down the lane with significantly thrombus-laden ACS, which was salvaged with a laser-assisted PCI without a distal protection device, 3 metal stents, making it a metal jacket, but beautiful result at the end with TIMI3 flow down the major vessels. Second case is of 78-year-old, cabbage done in 2012, unstable angina 2020, where underwent a PCI to SVG to PLV graft. Again, 4 years down the history, had again NSTEMI. CAG done, showed a thrombus-laden SVG to PLV. Treated with dual pathway inhibition, that is dual antiplatelets as well as NOACs. Continued to have angina despite the dual pathway inhibition. He came to our center about 1 month after the index hospitalization with NSTEMI. with dynamic ECG changes and refractory angina. Normal LV function. Native angiogram, native LMCA plus triple vessel disease. Lima is patent. SVG to diagonal and SVG to PD are the patent graphs. We go to the culprit. So this is the culprit lesion. The SVG to left-sided PLV graft. It is degenerated. It is fully thrombus laden, and there is a distal instant restenosis. This patient has come 1 month after the index end STEMI. We were really doubtful whether to even attempt, because it's a chronically, it's almost like a nearly lately arriving uploaded SVG. All our efforts with balloon PCI or conventional PCI in such a scenario has been futile. But this person was having recurrent angina despite being on anticoagulants and antianginals, dual pathway inhibition, and best antianginals that were on board. So dual antiplatelets and rivaroxaban was there. So we took him GR 3.57 French guide, workhorse via down dilution. O1 does not make any difference. We start doing a laser atherectomy, again guide extension assisted, 0.9 mm laser, gradually increase from 40-25 to 80-80, 5 minutes of slow lacing. So this is easier said than done, although on the slide we showed at 1 second, but there's a lot of time taken in this. As I said, again, guide extension assisted, we do a ballooning. We first do a 2.5 balloon, and then we, in the instant restenosis segment, we do a drug-eluting balloon in the instant restenosis. And this is the angiogram that we have. We have a reasonable good perfusion into the branches with myocardial blush, which is important. So this is a 12-year-old degenerated SVG, presenting 4 years later, completely thrombus laden with instant restenosis. We were really skeptical whether to take it on or not, but with laser-assisted a drug-eluting balloon PCI, no stents further use, laser followed by a drug-eluting balloon without the use of any distal protection device. We have TIMI3 flow in the branches and good distal flow. So late arriving SVGs, if you look at the timeline, as the duration of SVG occlusion prolongs, like for a late occluding SVG, the typical consensus is to try attempting PCI to the native vessels. But what do you do if the native vessels are very bad CTOs and for totally occluded SVGs? This is one way forward. That's why it is titled Never Too Late. These were 2 cases which showed that degenerated SVGs presenting as ACS, arriving very late, fully thrombus laden, for which PCI was abandoned because of late presentation at different centers. We were able to do with a laser-assisted PCI, in one case with multiple stents, the other case with a drug-eluting balloon, where clearly the message is slow and steady lacing would establish flow even in degenerated SVGs presenting late as acute coronary syndrome with good distal TIMI3 flow, no DPDs used. The second is the use of adjunctive technologies with laser in calcified lesions. This I presented in the recent India Live. So the first case was a 65-year-old unstable angina, recurrent angina despite medical therapy, calcified lesions, had calcified triple vessel disease, was not willing for surgery, came to us for multivessel PCI. So this was the RCA, long calcified long segment lesion. So it was a calcification with a tortuosity or calcification with a bend. OM had an ostial lesion. LAD had a proximal tight lesion. We dealt with the OM with a drug-eluting balloon. The OM had a typical ostial lesions, dealt with a drug-eluting balloon, 2.515 sirolimus eluting balloon with a reasonable result. We then ended on the LAD. Workhorse wire in the LAD. IVUS showed a 3 mm vessel. So we presented with a 2.75 non-compliant balloon and standard with 312 balloon, standard angioplasty to LAD with IVUS guidance with a good angiographic outcome. Then we come to the RC. So the RCA was calcified and had a PET. So calcification and tortuosity are actually because Achilles heel for us. Because when you have a calcification and a bend, it's very difficult to get hardware down, the devices down. So we have a GR 3.57 French guide, workhorse wire down. After that, no balloon crosses. The smallest profile balloon does not cross down. The IVUS catheter does not cross down. In fact, the IVUS catheter was damaged at the tip. Micro catheter doesn't go down. The guide extension support was used. With the micro catheter wedging, nothing works. We tried a grandoplasty with a 1 mm balloon, nothing. So this is the typical scenario where we have a calcific RCA with a bend. Sometimes a calcification of the tortuosity is the biggest Achilles heel. The workhorse wire is down. The guide wire extension is taken. So guide extension is taken. So this is a 7 French guide with a guide extension, which would actually replace an AL guide, because with a guide extension and a 7 French guide, you have good amount of guide support. So a guide extension with a guide plus is taken in. imaging catheter does not cross, the microcatheter does not cross, the granuloplasty fails, the smallest profile balloon does not cross. We tried wedging the microcatheter and trying to pass the rota wire. That's what we typically use in this scenario. We have the microcatheter taken it till the tip and trying to do a bare rota wire. We failed. So this is a scenario where you have balloon and microcatheter non-crossable lesions in a typical moderately calcified stenosis. ELCA works. So we get laser to our rescue. We start off with a 0.9 catheter, start off with 40-80, gradually to saline lacing, followed by blood lacing, increase to a setting of 80-80. And after 4 minutes of lacing, you can see even with the laser, we struggle. With the guide extension assisted laser, also the guide catheter backs up. But with the laser, we really are able to modify the lesion. Now, after the laser is done, we are able to get the microcatheter down. But laser actually softens the passage and gets the microcatheter down. Once the microcatheter is down, we have the rota wire down. We still try to pass a balloon catheter, nothing passes. So laser actually facilitates the passage of microcatheter. And once that is done, then we start the typical debulking, the calcified lesion, and rota is the way forward. So we start off with a 1.2 fiber, have at 140 to 170,000 RPMs, do a debulking, about 3 minutes of rota ablation, and we finally have a good polishing run done. Get the rota wire exchange to a Grand Slam wire to improve our support. We pre-drilled the 2O balloon and 2.75 cutting balloon. With 2.75 cutting balloon, we have absolutely no waste, so we don't escalate the bar further. We do a preparation with a 3O balloon at 3 into 12 non-compliant balloon at high pressures. There is no residual waste, so there's adequate preparation of the waste. And then with the guide extension, we have two overlapping stents, 3.538 and 3.548 placed. And this is the final angiographic outcome. IVUS guidance show that there's good outcome. And patient was discharged on day 3. So this is laser, typically laser plus rota on a calcific tortuous RCA. Wire and microcatheter, wire crosses, but microcatheter balloon does not cross. We do a guide extension, that is guide plus assisted lacing, followed by microcatheter pass, and then we do a rota cut and stenting. We had a similar case, non-ST elevation MI, LMCA plus triple vessel. We have a significant ostial LMCA lesion, surgical turn down, comes for PCA. We have a significant calcific ostial LMCA and a mid-LMCA, mid-LAD tight lesion. We have a workhorse wired out. We try to, with a laser for the L6, we just do a cutting balloon and stenting, 2.5 cutting balloon and 2.518 everolimus eluting stent. We stent the L6. Then we go on to the LAD. LAD is where, again, we had the Achilles heel, we had a calcified segment, but the wire crosses with the guide extension support also, no microcatheter, wedge microcatheter rota wire doesn't cross, smallest profile balloon doesn't cross, granuloplasty does not work, imaging catheter does not cross. Again, we do laser atherectomy, the same technique, 40-80, increase to 80-80, saline lacing with a guide extension assistance. You can see a guide extension assistance and saline lacing. And once you're done ELCA, your microcatheter goes down, and we are able to do a rota followed by a rota to further debulk. 1.25 rota bar in 2 minutes is able to do a good polishing run. And we have the bed prepared. We take a 2.5 cutting balloon and we are able to expand it with no residual waste. We have 2 stents placed, 2.7538 in LAD and 4O in the LMCA after both the areas were prepared with cutting balloons. And then we post-dilated 3.5 in the proximal LAD and 4O in the LMCA. LMCA was also prepared with a 4O with a 3.5 cutting balloon. And this is the final angiographic outcome. IVUS also shows a good angiographic outcome. So this was another case of laser cut, where we used a combination of laser plus cutting balloon, where you have wire across, the balloon or microcatheter does not cross. We have a guide plus assisted lacing, followed by a microcatheter passing down. We do a rota ablation, followed by cutting balloon and stenting. This combination of laser has been well established in trials and has been shown to be safer. And so this case eluded the benefit of laser in balloon or microcatheter non-crossable lesions. Subsequently, now we deal on with the most common indication, that is in unexpanded stents or balloon non-dilatable stents. So this was a 75-year-old post PCA in 2012, comes with NSTEMI with recurrent heart failure, which is actually precipitated by AF. He has recurrent angina. You can actually see a very tight LCX ISR, which was actually a 2.7524 stent placed about more than 10 years back. You can see the IVUS, which clearly shows a heterogeneous neointima. You also see a very underexpanded distal stent. and you have a proximal calcified lesion. The RC and LCX stent, RC and LED stents are patent. So this is an LCX tight ISR due to an underexpanded stent, presenting with recurrent episodes of AF and also having heart failure, probably because of significant MR. This tight significant ISR, we have a workhorse wire down, but none of the balloons cross. So we do a laser atherectomy, which is the best debulking technology in instant restenosis. We start off with 60-80, gradually with saline lacing, with blood lacing, we jack it up to 80-80, and we have the entire stent segment laced. Subsequent to the lacing, these were the initial set of cases. We were not very patient. We actually passed the laser like a microcatheter. After the laser, we tried to do balloon expansion. Again, you can see the underexpanded stent just doesn't expand. A balloon fails to expand. The 2.5 non-compliant balloon does not open. We try a OPN. The 2.5 OPN at 35 atmospheres also does not open. So we didn't go much higher pressures at this. We had already the laser there. We again do a repeat lacing. So now we go on 80-80. We do some amount of contrast lacing there after the saline lacing. And after the contrast lacing, the OPN, you can see the same OPN opens up. Now the same OPN, 2.5 OPN, opens up at 35 atmospheres after the laser. So this was actually a balloon non-crossable lesion and a balloon non-expandable lesion, where the OPN actually opened up after you had done a lacing. And subsequently, it is just the hybrid PCA. We actually prepare the bed with a 2.5 scoring balloon, and we treat it with a drug-eluting balloon that is 2.7530 distally, and the proximal LCX was treated with a stent that is 3x34 onyx. So this is a hybrid PCA. So we do a stent in the proximal segment and a drug-eluting balloon in the distal segment, and this is the final angiographic outcome, which shows a good outcome with a good IVUS also showing good expanded stent. So this was actually a tight LCX ISR. IVUS clearly showing an underexpanded distal stent. We had to do twice lacing, first for crossing the balloon across, and subsequently for non-expandable area of the underexpanded stent. Finally prepared it with a cutting balloon and OPN, and then did a drug-eluting balloon for the distal stent and a drug-eluting stent for the proximal calcified lesion. Now we do look at another degenerated ostial SVG. This was a 69-year-old diabetic hypertensive post-PCA 2018, had ISR for which a CABG was done in 2013. He came very early after CABG. In 2024, 1 year down the CABG, he comes with NSTEMI, lima patent, SVG to PD, a PLV occluded, and SVG to OM, you find a very ostial, very tight lesion. The lesion is so ostial that none of the guide catheters give any support. You have a GR guiding in, no guide extension process, balloon does not cross, imaging catheter does not. It's a very ostial lesion. You have hardly any support. You had hardly any support because there's no place for any extension catheter or the guide to wedge it. In these kind of cases, laser really works. You can have the guide floating in the ostium and you can lace with a 0.9 catheter, ostium to proximal, 60-60 starting on, good amount of time of lacing. We're able to cross the lesion. Beauty is with lacing, there's very less distal embolization. Then we subsequently prepare the 3.513 aperta balloon, and then we place a Megatron 3.512 and post-air it with a 4O balloon. And this is the final angiographic outcome. No slow flow, no filter use, no residual stenosis. So this was actually a balloon or imaging catheter not crossing, very osteoproximal SVG lesion, where we were able to first do a lacing, do a preparation of scoring balloon with no distal slow flow or anything. We were finally able to stent and get a good outcome. Subsequently, cases around non-dilatable lesions and thrombotic lesion. This was an inferior wall MI, present outside, proximal RCA, fully occluded. They wired, they pre-dilated. They found significantly organized thrombus. Despite balloon dilation, the distal there was poor flow. They left it there. And then they referred to us. Because one reason was they actually sent an image. It was just not a late presenting MI. At one point, the balloon was not yielding. You can see clearly a base there. At one point, the balloon was just not dilating. A 2.5 OPN also they had run. A 2.5 OPN at 30 atmospheres, the lesion was not yielding. And with the guide extension also, they were not able to make any. So this was a 2.5 non-compliant balloon at 30 atmospheres, did not yield up, and the OPN could not track despite using a guide extension, and they were referred for laser. So this was a 3.5 vessel. So as I said, a 3.5 vessel with a significant thrombus, the best debulking catheter is always a 1.4 LCA catheter. So here, this is one scenario where a 1.5 catheter works well in thrombus with a good debulking strategy, works at about 60-40. So with the laser, you are able to debulk the thrombus, and if you are able to do with the balloon non-expandable lesion as well. Subsequently, after the laser, you can see the scoring balloon well opening up, the non-compliant balloon itself opening up, and then we stent it with a 3.528 stent, post-dilated 3.5 non-compliant balloon. And this was a late arriving thrombus, which was non-balloon dilatable. You can see the first lesion is where the MI of a late presenting fully occluded late arriving thrombus, where they tried angioplasty. A 2.5 non-compliant balloon had a significant non-dilatable lesion at 30 atmospheres. We did a 1.4 laser, and then subsequently a scoring balloon and drug-eluting stent does the work. Subsequently, again, we go to ISRs. So we had this was a calcified triple vessel disease. RCA stented with 3 stents, metal jacketing done. LED significant calcific ISR. You can see LED long segment calcific ISR. We do a COBA to serve. Ramus was stented. We start working on the LED. We start, since it's a long segment ISR, we start doing a laser at 0.9 catheter 60-60. We subsequently prepare the 2.5 non-compliant balloon and 2.75 non-compliant balloon. None of them yield. We tried a scoring balloon also. None of the balloons yield. You can see a balloon non-dilatable lesion. So it was an instant restenosis, long segment lesion with a non-dilatable focal segment. So here again, we tried with a high pressure dilatation with a 2.5 balloon at 30 atmospheres, failed. We tried a smaller size OPN, 2 OPN at 55 atmospheres. So there was a school of thought which came when if you're using a smaller size OPN, we can go very high pressures. We tried that. We tried a 2 OPN at 55 atmospheres. It didn't open up. So again, we get back the laser catheter. We do a contrast lacing at 80-80. And then we are able to take care of this balloon non-dilatable lesion. After a laser, this 2.5 non-compliant itself opens up. We subsequently prepare the 313 cutting balloon, and we place 2 overlapping stents, 2.7533 and 2.7548 from LMCA to LED. Do LMCA pot at 4O with a 4O balloon. And this is the final angiographic outcome. So this was a very calcific long segment instant restenosis in the LED, where even after lacing, we were able to debulk, but we had a focal area where balloon was not yielding. The cutting balloon, OPN, everything failed in that. So we do a repeat contrast lacing at 80-80. And finally, we're able to debulk, and we're able to do a bed preparation of the non-compliant balloon and place 2 overlapping stents. This is another case of RCA CTO. This was a person with effort angina, RCA CTO. We were able to cross a wire. We have had a field XT wire down, but after the wire crosses, the balloon, or as I said, the Nick Nano, the smallest profile alveo balloon, and Nick Nano doesn't cross. The right action support does not make much difference. The microcatheter also does not cross. So this is a typical balloon microcatheter non-crossing CTO, where we have a laser catheter, again, slow passes, multiple passes, fluence 80-80. And once you have the laser catheter down, you're able to prepare the focal area with a cutting balloon 313, and we stent with a 3.520, posterior 3.5 non-compliant balloon, and this is the final angiographic outcome. So this was an RCA CTO, where we were able to cross the wire, but after that, no balloon, microcatheter, or rotawire crosses. So we do a laser plus a cutting balloon and finally stent to get good angiographic outcome. Thrombotic lesions. This is this is my final case. This is in fact one of the nightmares that we had. So it is not always everything ends very rosy. Sometimes in these lesions, you might end up with catastrophe. So this was one of the catastrophe or nightmare that we had with laser. This was a story of 44-year-old anterior MI. He presented 72 hours after his MI, had ongoing angina. Echo showed preserved LED thickness. So you can see the LED was occluded with a chronic thrombus, almost a subacute thrombus. RCL6 was normal. It was a late arriving thrombus. We have passed the wire. Balloon dilatation does not create any impact. So we thought of doing laser. Laser works well for late presenting MIs, well-organized thrombus. And laser works in these scenarios because it reduces slow flow as well. So this was been our experience. So late arriving thrombus, laser really works well. But this scenario, the issue was we had the wire down. We used this 0.9 laser catheter, started 60-60. Only issue was it was fully occluded vessel. We never knew where the distal vessel was. And as we start lacing, patient suddenly complains of severe chest pain, and check angio clearly shows a type 3 perforation. So we have a type 3 perforation. Probably there was a bridge segment there. We were not clearly, or the wire had a subintimal pass. We typically have a type 3 perforation happening. We quickly do a balloon tapered at 315 balloon. We don't reverse heparin at all in these scenarios. So this is the type 3 perforation. We do the typical approach is to have a ping pong guide, but we were confident that we would be able to manage a single guide approach. We do a balloon tampering, quickly exchange it through a guide plus EL. So our typical approach is we have the guide plus EL tracked down to the site of perforation. We check in with the guide plus EL, which actually shows the exact site of perforation. And through the same guide plus, we pass in a Graftmaster 2.826 deployed at 16 atmospheres. And then proximal AD stent with 330 drug-eluting stent. And we post-dilate the whole vessel with 3.512. We were able to do it fast enough so that we never needed a pericardial drain. And this is the final angiographic outcome. This patient was quite stable and got discharged on day 3, doing good on clinical follow-up. So this was a nightmare where we tried laser for thrombus, landed up in a type 3 perforation, probably because we might be a bridge segment or it was a subintimal pass. Finally had to be salvaged to the covered stent and a proximal drug-eluting stent. But we are able to manage it through a single guide and everything, all that ends well. So finally, to conclude, in a nutshell, laser is an adjunct to PCI. It facilitates easy delivery of stents and balloons. It definitely reduces your maze by ensuring better stent apposition and expansion. And your balloons, you will easily find that those balloons which never expanded had non-dilatable effect at high pressures. After laser starts expanding at very low pressures, you have significant amount of debulking happening. And this is a technology that works across the morphology of plaques. This is one technology which will work on moderately calcified lesions, heavily fibrotic non-dilatable lesions, balloon or microcatheter non-crossable lesions, and at the same time work on soft plaques like late arriving thrombus, degenerate SVGs, at the same time debulking without any distal embolization. But whenever using laser, remember the 5S of laser. Select the right kind of patient. Use it for balloon or non-crossable, balloon or microcatheter non-crossable CTOs. Instant restores the safest bet for laser. Degenerate SVGs is one of the phenomenal ways where laser has worked, where even chronically occluded SVGs, we were able to extend the spectrum and use it. Calcified lesions, again, keep your expectations low. Balloon or microcatheter balloon non-dilatable lesions, this works really well. Ostial lesions where you cannot have guide catheter support, laser works well. Diffuse lesions, laser works well. Underexpanded stents, laser works well. Size of catheter, remember, it's always better to use 2/3 of the size of vessel or 1 millimeter less than size of vessel. So if you're using, typically you lace only vessels which are more than 2.5. And in 90% of cases, your 0.9/80 is going to be a workhorse catheter because it has highest fluence and highest pulse capability, works through 5 French and 6 French guides, allows you about 10 seconds of lacing and 5 seconds of rest only. The key is slow advancement with laser, slow advancement and multiple passes. So the advancement should be less than 1 millimeter per second. The slower you go, the better luminal gain you will get. The settings typically is to start with lower settings, that is 30 or 40/25, and then gradually jack up your settings to 80 fluence and 80 pulse, and go gradually and hike up your fluence and rate as you go to subsequent passes. And do always saline lacing first. Have your catheter, have your vessel fully flushed off with saline, and then have 2 to 3 saline per second of flush. Do saline lacing first. Subsequently, if it doesn't work, do blood lacing. And if that also does not work, only in instant restenosis areas where you are working in a safe environment of standard segment or concentrically calcific segment, try saline lacing. But again, with saline lacing, prepare to watch for complications and have a higher set of complications. So only after initial set of experience goes up, you contrast lacing. So that's all from my side. This will be the reference references which can be used for working out on what all would improve your understanding on laser. But that's all from my side, and I will be happy to take on any questions.
Yeah, so it
Yes.
was a wonderful presentation, and I see Dr. Puneet Verma there. Sir, it's a great pleasure to see you again after a long, long time.
Hello, hello everyone. Yeah,
Sir,
so nice to see all of you.
So Arun, laser, as you said, has been there for more than 30 years, and you have done some wonderful cases. Really, congrats, excellent. Now tell me, why has the laser not caught up so far? And second, how do you charge these patients?
Okay, sir. So initial
Heavily.
issue, yeah. So initial issues with laser where they were said, you can see 30 years of data and experience, everything was there. But they had some set of issues actually, the way they were using laser, they were using it as a very aggressive tool. So over time, it's like renal denervation. It's actually, I have a comeback with the newer technology. The newer system is much more handy. And our understanding over time of the use of the technology has made us use it in a more safer way. It is only the way we are doing it has changed, and that has refined. And now we find it much more useful, typically in this kind of late arriving thrombus, degenerated SVGs, and balloon or microcatheter non-crossable lesions, where laser is the best way and your best, safest bet to get away without much set of complications. So, provided you use saline lacing and remember the 5S of laser, your set of complications tend to remain low. And it's a very safe technology and a very short learning curve. But again, as your learning curve goes up, you can go to a higher aggressive mode, including contrast lacing. But again, be prepared to face those sets of nightmares, and you just need to deal with them. That's all.
What about
So
how do you
prior
charge
to
these patients?
2003 or 6, the laser was actually, it's a long laser rather than short laser. And that had more thermal injury causing to coronaries and leading to more dissections and perforations. After the Excimer, the short laser has come. It's a cooler technology. It does not result in coronary perforations and dissections. And then only it had caught up. And now it's almost, and secondly, you can use it for severe calcification also. It's not that only that you have to have longer run time, more patience, and it will ablate like what Dr. Aruna has done, that he has finally was able to pass a rotawire. So that part, at least it can, pave way for the rotawire, and then rest of the things can be taken care.
I think
How
we
do you
should
charge
congratulate
patients?
Smith. Smith was the one who introduced laser in the country, and he's one of the pioneers for use of laser. Yeah.
How do you charge these patients? I believe you are in a private
Yeah.
setup.
Yes, a laser catheter we tend to use. Laser catheter we use. Typically, each of our catheters, we have at least got more than 8 users in, almost close to 6 to 8 users in a catheter. So laser catheter gets charged, catheter cost about between 2.5, close to 2.5. So we split charges.
Okay, perfect, wonderful, excellent. Yeah, sir, anything else, Dr. Puneet?
Sir has also bought laser system recently.
Yeah, it was nice listening to Dr. Gopi's case presentation. I joined in late actually. Was doing a laser only in one of acute amyloids delayed presentation cases. So out here in Punjab, in our practice scenario, we get a lot of these cases who come out of the window period of even thrombolysis and of course sometimes delayed ongoing uh, ischemia, and then you go in and it's a great tool to actually use in relatively older clots, and it works quite well. Except I generally start with 40-40. I mean, I don't really go in for lower fluencies. Of course, is 40, but frequency I generally start at 40 only. And as Dr. Gopi said, yeah, the more with more experience, you will certainly get confident with even ablating calcified lesions and the deeper calciums too, conditional that yes, you are ready to, you have all the tools with you to take care of perforations and the other ancillary things. But otherwise, I think it's a great tool to have in the cath lab, especially when we are doing complex interventions, and it really helps. The Nd:YAG and the argon were the earlier lasers which had come, which were in the infrared range of the spectrum of the light, and therefore they had greater penetration and therefore greater thermal injuries in the coronaries, as Dr. Smith said. But the excimer laser is, of course, a cool laser, and of course, its penetration is not as much as the earlier lasers. But then I think if you want to ablate the higher deeper calcified lesions, then you need to go in for sequentially or higher energies or go in for contrast lasing, which of course carries its shares of issues. So early on, of course, we've not been using it in these kind of lesions, but yeah, now selectively I do calcium with laser, but it's only selective. But
One
and another great tool for underexpanded
yeah,
stents,
definitely.
and no doubt about vein grafts, and even in acute myocardial infarction, in case you want to do it even within the window period. The great thing about this is the no reflow phenomena and all slow flow is practically not there. Once in about, I think I have now done about 150 plus cases, so one or two cases, maybe one case I remember where I had to put an IABP in that patient, and otherwise to for the slow flow. But otherwise, it's been a great story so far.
One question in my mind was that in all these patients who have delayed presentation, so thrombus is organized, it's always very hard. It's a nightmare actually to get a good flow down the vessel. So once you do the laser, are you able to get a reasonably viable myocardium down, or is it already, I mean, what has been
Yeah, I
your
mean, I mean, see, if the myocardium is not viable, then obviously I think you will have issues of flow anyway. So here we are actually discussing delayed presentation, but evidence of is ischemia which is ongoing. So there, of course, we don't just like to go open it. I mean, people would. There are still proponents of thromboaspiration, no doubt. People would use an export catheter or anything, and but laser thrombectomy in this scenario works. I think it's the safest tool to have
absolutely?
because by its mere photochemical and photothermal properties, it's able to take care of the thrombus. And the only issue is that, yes, you have to be very focused to do saline lasing. That's important in myocardial infarctions. You should not actually be looking at any form of contrast or even blood lasing. It should be all saline lasing, preferably. Preferably if your guide is not too coaxial, it should be with the help of a guide extension catheter, which actually directs your saline typically at the site of the lesion.
I will show that beautifully. Yeah. Smith, any comment?
Yeah, sir. But I feel like most of the times we end up using export catheter. It's very rare that the laser would be able to ablate the whole of thrombus. Yeah, but it definitely makes the reason is that lasing actually inactivates the activated platelets. So it suppresses platelet activation. So that is an added advantage. Then other ablation, any other ablation. So you have rota, orbital, or IVL, anything else, it would actually activate the platelets and it will cause more no flow or reflow, slow flow phenomena. But laser, on the other hand, it actually, that is why in all those SVG cases, Dr. Gopi did not use a distal protection device and he could get away with a very good flow.
Yeah. And all of them are very bad actually.
Yeah. But the operator was good.
Yeah. Yes. Excellent. So I think that brings us to the end of this today's
Yeah.
meeting.
So, yeah.
Sir,
So
it's been a
just one
pleasure to-
announcement, sir. Next month we won't be having a master class because we'll be meeting all at Delhi.
Yeah, and I
So the
want
next,
Dr. Puneet, sir, you must come 12th and 13th of April. Dr. Puneet, can you
Yeah,
hear me?
yeah,
Sir, you
yeah.
should. I spoke to you, sir. Are you coming?
12th, 13th April, I have a bit of some family challenges at home. It's actually my son's wedding preparations are on.
Acha,
And
acha.
I wish I could join all of you guys, but I'll still, I don't promise, but I'll still try to be there.
So nice of you, sir. Really appreciate. Sir has been a great teacher to me, actually. Okay. So when I was, I think DM first year, sir was assistant professor, and he was one of the most benign and most gentle people to be with, because all others were very hard to be around. I think Dr. Puneet Verma and Dr. Mandeep Singh, who is at Mayo Clinic in US now, these were the only two people we could dare to talk if we were in trouble. Otherwise, very hard. Thank you, sir. Thank you so much
Yeah.
for that.
Chalo, I think you had a great meeting actually today, and I hope to be in touch with all of you in these
Thank you, sir.
fora.
Thank you so much.
Yeah.
Yeah.
So we have it
Thank you.
on every fourth Friday, sir, 8 to 9:30.
No,
Every
wonderful.
fourth Friday, 8 to 9:30.
Wonderful. I
most
just
welcome
saw
to
your
join.
message. In fact, I saw it a bit late, but then I thought I must certainly acknowledge your inputs on my WhatsApp. Thank you so much.
Bye-bye, sir. Bye,
Thanks.
everybody.
Thanks.
Thank you.
Bye bye,
Thank
everyone.
you.
Bye.
Thank
Bye.
you.